Hello to all my colleagues of the Chinese Society of Nephrology. I bring to you greetings from the International Society of Nephrology, which is celebrating its 60th year. And I would like to first of all congratulate the entire Chinese nephrology community on completing 40 years of the Chinese Society of Nephrology. I would also like to express my thanks to the program committee leadership of the Chinese Society of Nephrology and to the executive leadership of the Chinese Society of Nephrology for inviting me to talk to you today on a topic that is really something which is of interest to the entire world, that is COVID-19. So I'm going to talk a little bit about what has COVID-19 taught us as kidney health professionals. So this particular slide shows us the coronavirus timeline. And on the bottom line, you see the comparison of the coronavirus outbreak timeline, which started somewhere in December 2019, to the SARS outbreak, which happened about 11 years ago. And both incidentally started in China. But you can see how fast progress was in the coronavirus outbreak. Just within a month of the first patient being identified, the virus was identified by Chinese scientists, and the sequence of the virus became available. And very soon after that, once human-to-human transmission was confirmed, the Chinese authorities instituted a strict lockdown in Wuhan, which led the WHO to declare it a public health emergency of international concern and subsequently declaring it a pandemic. Now, different countries around the world have responded to this pandemic in different ways, and we see that we continue to still battle this pandemic in our different ways. Even though we know that the predominant manifestation of coronavirus infection is lung injury, extrapulmonary manifestations of COVID-19 have been recognized in quite some detail now. And we now know that coronavirus is really a systemic illness infecting a number of organ systems, starting from the nervous system to kidneys to liver, gastrointestinal system, coagulation system, heart, of course, endocrine system, and skins as well. These systems are involved both in the short term, but also as we are recognizing some of the involvement lasts for a long time. We are going to speak about the kidney manifestations of COVID-19. And this slide shows you the main kidney manifestations of COVID-19 that have been recognized around the world. And they include a range of urinary abnormalities, including proteinuria and hematuria, acute kidney injury, electrolyte abnormality, and other tubular function defects, metabolic acidosis, and much more recently, glomerulonephritis has been recognized as well. Not indeed kidney manifestation, but important for patients with kidney disease. Those on dialysis experience increased incidence of extracorporeal circuit clotting. This is also a slide which shows the same information, but now focusing on acute kidney injury. Acute kidney injury was not really described in high proportion in the initial reports coming out of China, specifically from Wuhan. But later, as the pandemic moved to Western Europe and North America, the incidence of acute kidney injury went up to as high as 50% in those admitted to intensive care units, but a more generalizable estimate was between 15 to 30%. And again, the need for kidney replacement therapy, most frequently continuous renal replacement therapy, was identified in about 1 to 17% of those individuals. Acute kidney injury clearly was more common in ICU settings. And as I have mentioned before, other urinary abnormalities, which included proteinuria, hematuria, or a combination of the two, were much more frequent. Now, the other thing which came to light during this pandemic was the resurgence of peritoneal dialysis as a means to treat individuals with acute kidney injury. This is data from one hospital in North America. And you can see that as the caseload of patients with acute kidney injury due to COVID-19 who required kidney replacement therapy rose, Initially, that therapy was provided predominantly through hemodialysis and CVVH, but as these services were overwhelmed, quickly peritoneal dialysis emerged and really became the predominant mode of kidney replacement therapy in individuals who developed acute kidney injury due to COVID-19 in this specific hospital. It also offered a number of advantages, one of which was a reduced need for the healthcare worker to come in contact with an individual who was affected with COVID-19. For example, in this instance, you can see that the peritoneal dialysis cycler has been placed outside the room where the patient is. And so the healthcare worker doesn't need to really put on heavy personal protective equipment every time they have to go and change the dialyzer settings. Now, let's talk a little bit about patients who are on chronic dialysis and how their care has been affected during the COVID-19 pandemic. So one of the first things that the International Society of Nephrology did is by working with colleagues in China, and here you can see this paper which was led by Professor Sarla Naicker of South Africa, but you can see a number of colleagues from China as authors on this paper, which was published in Kidney International in the month of March, and it provided guidance to colleagues around the world on how to manage patients on chronic dialysis during the COVID-19 pandemic based on the guidelines that were provided by Chinese colleagues. And this paper was published in Kidney International and subsequently was translated into a number of other languages. Here you can see Dutch, you can see Spanish, and you can see Portuguese, and other languages also came through. And thereby experience from China really was of value to colleagues around the world. It also led us to develop a hemodialysis unit reference guide for dialysis in low resource settings. And this was used by many units to create preparedness checklists. And those checklists gave some guidance to colleagues on what to do in different situations. For example, how do you modify or adapt the existing environment, both outside the hemodialysis room, inside the hemodialysis room, and once dialysis is being conducted, what are the best practices for staff and patients, which we now know very well, but at that time it wasn't so obvious. For example, washing hands and not reusing linen and use of masks, etc. Subsequently, data has emerged which shows that COVID-19 is common amongst dialysis patients and it presents atypically. Data from US Medicare has shown that beneficiaries who had end-stage kidney failure were 3.5 times more likely to get COVID-19 compared to non-ESKD beneficiaries in US Medicare scheme. Patients on dialysis were likely to have less fever and dry cough and presented more with fatigue, anorexia, and hypoxia. And what is really interesting to note that these are the features which are common in patients with uremia even otherwise. So one needs to maintain a high index of suspicion to identify COVID-19 infection in patients on hemodialysis. Data from China and other places has also shown that lymphopenia and CT scan abnormalities are more frequent in our dialysis population and might be used to identify these subjects. Disease course of COVID-19 is more severe and virus shedding persists for a longer duration. So in this particular paper published in Journal of American Society of Nephrology, we can find that asymptomatic SARS coronavirus infection is really seen commonly in hemodialysis units. So you can see data from this one unit, which was dialyzing about 376 subjects, out of whom 121 developed symptoms. And they underwent both PCR testing because they had symptoms, and subsequently they underwent antibody testing. Those who did not have symptoms were also offered antibody testing. A number were either unable to provide samples or declined consent, but a significant number who did not have PCR also subsequently underwent antibody testing. The findings of this study are that whereas a vast majority of individuals who were PCR positive developed antibodies, about about 20% of those who were either PCR negative or who did not have PCR also were found to be antibody positive, suggesting that they had, in fact, acquired coronavirus infection, but either were asymptomatic or did not get tested because, of course, they were asymptomatic. Now, what this particular data taken from a European database shows that development of coronavirus infection increases the probability of death in individuals on dialysis. So about 25% of people are likely to die who have been on hemodialysis and have developed coronavirus infection. And the two factors which are associated with worse outcomes in this study was increasing age, here shown on this axis, and frailty score. So people who were older and who were more frail were likely to have the highest risk of death in this particular study. The second thing to note is that coronavirus shedding is prolonged in dialysis population, which means that somehow the virus does not go away as soon as it does in general population. This is data from one unit which did coronavirus testing every 48 hours in 19 of their patients who were coronavirus positive. And what it showed that whereas a majority of patients or almost all the patients were positive for at least 10 days or so, a substantial proportion remained positive for even as high as 50, 60 days, which means that unlike in general population, you cannot make the assumption that a patient is likely to become negative after about 2 weeks or so. So as a result, the recommendation is that the isolation of hemodialysis patients should be done in a planned way. This information is important because we dialyze our coronavirus positive patients in a separate unit, and we do need to be able to identify when they do not remain infective so that we can take them back to a negative unit. So according to this algorithm, for patients who are afebrile after having been tested positive, swab should be repeated 7 days after the initial positive swab. If it is negative, repeat it once more 48 hours later. And if it is still negative, you can take them back to their normal hemodialysis units. But if the swab is positive, then you should repeat it every 48 hours and re-swab these individuals every 48 hours until 2 consecutive swabs are negative. These authors found that just under 9% of these patients could be de-isolated in less than 9 days, and this proportion increased to 35% in 12 days and 60% in 14 days. What it means that almost 40% of the individuals remained positive even after 14 days, and so they need to be continued on in the isolation area as well. The other thing which has happened as a result of COVID-19 is the recognition that more use of home-based therapies might be beneficial. And how do we do that? We need to take some enabling steps, which include enhanced virtual or online training resources, both for patients and healthcare workers. We need to promote percutaneous PD catheter insertion. We need to develop pathways for urgent PD start and provide transitional care. We need to improve access to assisted peritoneal dialysis for patients who are unable to do peritoneal dialysis by themselves. Increase in telemedicine use is likely to be helpful by reassuring patients that they are in contact with their healthcare workers. But more than anything else, we need to educate our policymakers and insurance providers around the world that peritoneal dialysis is really more beneficial. Now, you are a little bit ahead in China because China does adopt a PD preferred policy, not really a PD first policy, but PD preferred policy. So we have a lot of things to learn from you. Let's now talk a little bit about kidney transplantation. So transplantation activity has come down drastically around the world, which has led to a lot of psychological impact, such as fear and uncertainty in the minds of patients who are waiting for a kidney transplantation. There are a number of important questions which come to people's minds. And some of them are, can COVID-19 be transmitted through a transplanted organ? Is it safer to stay on dialysis or to get a transplant? What is the outcome of COVID-19 in immunosuppressed patients? And finally, do kidney transplant recipients develop an immune response to COVID-19 or not? So here are some facts. If a COVID-19 recipient if a kidney transplant recipient develops COVID-19, they are much more likely to have acute kidney injury. The figures are shown there, 32 of almost 90% in hospitalized kidney transplant patients, and about 4 to 11% of these will likely experience graft loss. Why do they experience graft loss? The mechanism of injury is proposed to be either due to direct cytopathic effect of the virus or infiltration by CD8 positive macrophages, and finally, likely complement activation by the virus itself. Patients who have received a kidney transplantation are at high risk of complication of COVID-19 because, of course, they have several comorbidities. For example, they may have diabetes, high blood pressure. They may also have chronic kidney disease because the graft function may be suboptimal. And they are, of course, on immunosuppressive therapy, which also increases the risk of complications. Here is one study from more than 1,200 French kidney transplant recipients, out of whom 66 patients, which is 5%, developed COVID-19. And the factors that are independently associated with severe disease included non-white ethnicity, obesity, presence of pre-existing respiratory diseases like asthma and COPD, and diabetes. Now, in terms of mortality, whereas the overall mortality in the general population was about 1%, but in their COVID-19 positive kidney transplant population, it jumped up to about 24%, which tells us that kidney transplant recipients are at increased risk of mortality if they develop COVID-19. Now, let's just move to patients who have kidney disease. So what are the issues that are faced by patients and clinicians that might complicate their care? Because of COVID-19 and because of lockdown, they experience restricted access to hospitals and medicines. And the various types of medicines are listed here: immunosuppressive medicines and prophylaxis medicines. There are challenges with physical distancing because these people have to work, they have to sometimes travel, and they have to be with family members. Many of these individuals may have associated risk factors for poor outcomes like hypertension, diabetes, cardiovascular disease, etc. And since many patients with kidney disease, such as those with glomerular diseases, etc., they receive immunosuppression, it may also interfere with antiviral immunity, especially because they might have developed hypogammaglobulinemia, or they might have impaired cell-mediated immunity as well. So in this paper, Dr. Ansh Yogic Anders and colleagues provided a way to risk stratify patients with kidney disease in terms of those who are at a low risk of COVID-19 complications and have a high ability to raise an effective antiviral immune response, and those who are at high risk of COVID-19 related complications and have a low ability to raise an effective antiviral immune response. So you can see that people who are younger have a better GFR and have no proteinuria, normal IgG levels are in the green zone, whereas those who are older, who have active disease, who have reduced GFR, who have severe proteinuria, etc., they are at greater risk of developing complications. And of course, use of immunosuppressive agents further increases the risk of complication. So what are the key considerations that we need to keep in mind? We need to reinforce the general recommendations on hygiene, physical distancing, use of masks, etc. We should replace physical visits with telemedicine to the extent possible. We should use risk stratification for decision making, and risk stratification I had shared with you in the previous slide. We should perform individual risk benefit for hospital visits and kidney biopsy. For example, in a patient who is experiencing rapid decline in kidney function, it may be appropriate for us to call that patient to a hospital and perform a kidney biopsy. Whereas if there is another patient who simply has some degree of proteinuria and is otherwise stable, we can manage that patient at home, and their kidney biopsy can be delayed. We should consider tapering immunosuppression if the patient is in remission for a long time. And worth reminding is for us not to stop renin, angiotensin, aldosterone system inhibition if they are being used currently. We should also not deny admission to anyone who needs admission, and remember to use stress dose steroids in anyone who has recently received steroids. Viral screening should be done even if patients are not symptomatic before starting immunosuppressive therapy. And the final point is that we should consider COVID-19 when a patient presents with a flare, for example, a patient with lupus. If a patient with kidney disease has been exposed to someone else with COVID-19, again, we can do risk stratification. If the patient did not develop COVID-19, then we should just reduce steroids if clinically justified, reduce cytotoxic if the patient is lymphopenic. We might consider IVIG if there is hypogammaglobulinemia, and if plasmapheresis is needed in such an individual, use fresh frozen plasma rather than albumin as a replacement fluid. On the other hand, if the patient has moderate or severe COVID-19, you might consider either reducing or stopping some immunosuppressive agents, and even if needed, hospitalize them. And if you are planning to use any boluses, for example, methylprednisolone, cytoxan, postpone if possible. You can assess immune markers like dsDNA levels or ANCA levels, and if needed, you should measure drug levels also. Again, reminding you to substitute stress dose hydrocortisone in all of these individuals. And if the patient has COVID-19, it should be treated as per local protocols without any consideration for kidney disease if disease is severe. What about treating patients with COVID-19 if they have a background of kidney disease? So the first thing to say is that there is no clear guidance there. Many drugs have seemed promising for treatment of COVID-19, but have failed to hold up on rigorous scientific scrutiny. And the only advice we can give at this stage is to base decisions on patient characteristics, doing risk stratification, phase of the illness, whether it is mild, moderate, or severe, etc., and how many days have gone by. But when we do this, we should remember the possibility of drug interactions and the need for dose adjustments in those with chronic kidney disease. And all patients should be carefully monitored for the possibility of kidney-related adverse events. This particular slide is simply meant to show that continuation of angiotensin converting enzyme inhibitor or angiotensin receptor blocker during hospitalization in patients with COVID-19 reduces the likelihood of ICU admission, reduces the level of inflammation by lowering peak C-reactive protein levels, and reduces the inflammation score as well. So by all means, one should not stop or discontinue angiotensin receptor blockers. Now, as I said, COVID-19 associated glomerular disease has been recognized, and this paper was published just about last week in JASN, which looked at individuals who had COVID-19 and presented with proteinuria acute kidney injury. They underwent kidney biopsy, and they were also genotyped. And what they found is that ApoL1 genotype was associated with the risk of collapsing glomerulopathy and podocytopathy. So, African American individuals who have ApoL1 genotype abnormalities are much more likely to develop glomerular disease if they have COVID-19. So coming towards the end, what are the lessons for the practicing nephrologists? And we have to come back to basics, implement and follow strict infection control measures, use a good test for COVID-19. We should continue to be aware of atypical presentation. If we are managing dialysis patients, we should be prepared for logistic challenges and make sure we have adequate supplies. We should implement shared decision making by talking to our patients and making sure that we understand what the patient wants. We should encourage switch to home therapies such as peritoneal dialysis wherever possible. And we have become over time proficient in virtual care, which of course offers a number of advantages. It does not allow you to go and actually check the temperature of a patient. But if we use it properly, there are a number of things we can do using a remote monitoring technology. For example, if as a nephrologist, we can equip our patients with a thermometer, with a glucometer if they have diabetes, with a blood pressure instrument, and with a pulse oximeter. We can use the cell phone as a medium of communication, and the cell phone can directly talk to all of these devices using Bluetooth and then using wireless transmit that information to the healthcare provider, either the nurse or a doctor, and thereby allowing real-time monitoring of those individuals. And before we go, the initial impression that once a patient with COVID-19 recovers from acute illness, they will be back to normal has been challenged by the recognition that patients with COVID actually continue to suffer from a number of symptoms. And now we have this new terminology which talks of acute COVID-19 in the first 4 weeks, ongoing symptomatic COVID-19 between week 4 to 12, and post COVID-19 syndrome if an individual has either symptomatic or laboratory abnormalities even after 3 months. And new research is needed to understand the factors that will predispose someone to develop post COVID-19 syndrome, and what are the interventions that we can do to reduce the likelihood of development of COVID-19 syndrome. Having discussed all of this, we do recognize that at this stage, the most effective public health intervention is this lowly mask, which is available everywhere and in many sizes, many colors, etc. And this particular slide shows you the ice and staff here, shown here in this slide, took up the masks, wear a mask challenge put out by WHO, and this was recognized by the Director General of WHO with a thank you message as well. So with that, I would once again like to thank you for the opportunity to talk to you. I would invite you to come to the virtual World Congress of Nephrology, which is scheduled for April 2021. It was supposed to be held in Montreal, but will now be a virtual meeting. I recognize that the abstract submission deadline would have passed by the time you are hearing this particular presentation. And I do hope that you have submitted abstracts in large numbers, and that we will have the opportunity to meet virtually during this virtual WCN 2021. Thank you very much for your attention.